Good evening. This is Dr. Bernstein with our Wednesday, October 28th, 2015 teleseminar. Before we answer some questions, I want to tell you about the next broadcast, which will be Wednesday, November 25, 2015. And I want to give you the usual little warning. The information that I get from people who ask questions is certainly not a complete history, and we don't want a complete history. So I cannot give a precise answer. It's a guess answer. And you have to take that, my answers with a grain of salt. Now, that doesn't mean that when you send in questions, you should give me a 2-page history, because our screener will automatically throw those questions away. We'll answer the briefest questions we can get first. So if you want an answer, make it brief. I'll make certain assumptions about the history that might be incorrect, but we're looking toward the general audience, not for solving individual problems exactly. Now, the first question, before we go into questions, we have a special subject this week, which I'll quote the article. DHEA counteracts advanced glycosylation end product formation. This is an article published in Diabetes Care a number of years ago, but it's still pertinent. I stumbled on it when I go through my reminders of important facts. Many people have asked me on these teleseminars over the years, how do we stop glycosylation of proteins in the body? That assumes that you're going to have elevated blood sugars. We know that most of the complications of diabetes are caused by the attachment of glucose to important proteins throughout the body. We've gone into detail about some of these things in the past. And if we could stop this from happening, we could prevent many of the complications of diabetes. Well, the best way to stop this from happening is to have normal blood sugars. And as those of you who are using my book, Diabetes Solution, know, that's not too hard to do. But you have to control your overeating if you eat too much carbohydrate. And you have to stop following ADA guidelines that recommend high carbohydrate. So, number one is normalize blood sugars. For those people who can't possibly control their overeating, DHEA, which is dihydroepiandrosterone, and is a precursor to testosterone and estrogen, is something that apparently inhibits glycosylation of proteins. And I have the article over here, and those of you who want to go to the original source, this is from Diabetes Care, Volume 30, starts on page 2922. And this was from the year 2007. Now, DHEA you can purchase at most health food stores. I can't testify about the quality of all different sources of DHEA. You have to use a reliable manufacturer, and you don't want to overdose yourself. So I would think that depending upon your size, and certainly not for children, we would probably take 25 or 50 milligrams per day. But this is speculation based upon one article in one major journal. So that's about the information that I can give you. First question. I have elevated GAD65 antibodies. My blood sugar is elevated even on a low-carbohydrate diet. I would like to know if there's anything I can do in conjunction with diet and exercise to restore beta cell function and avoid clinical type 1 diabetes. Well, if you're already on a low-carbohydrate diet, and of course, I don't know what your low-carbohydrate is, let's assume that you're following my book and taking my advice. If it's that low and you're still getting elevated blood sugars, then you're clearly diabetic. Question is, are you a type 1? Well, you have GAD antibodies, so you're likely to be type 1, although we now know that type 2s also can be found making antibodies. But let's say that your genes are predicting type 1 diabetes. The best thing that I can think of is normal blood sugars. And this has been shown in a number of studies. In my book, we cite the very early one by Gerald Raven, where he gave type 2 diabetics, hooked them up to an artificial pancreas and kept their blood sugars at 90 for 2 weeks. And they kept making more insulin for the next 2 years. So we do get beta cell recovery in the presence of normal blood sugars. That's all that I know of for sure. There may be all kinds of products that might help, but I don't think they help a lot. Sure, metformin lowers insulin resistance. If you're overweight, it might help lower your blood sugars somewhat. But the combination of diet, exercise, and if need be, insulin is the best bet that I know of, at least in my experience, for putting off further deterioration of blood sugar. And I've seen this in a number of patients. Next question. Type 1 diabetic for 39 years. So this fellow is it's a lady, she is a survivor. I am 41 years old. I recently had a vertical gastric sleeve. After surgery, I lost 25 pounds, but still need to lose 80 more. So this person probably has been an overeater for most of her life and probably has been eating a lot of carbohydrate. I then began following your way of eating. I do not eat carbs at all, yet I am not losing any weight. What can I do? Well, first of all, read my book, Diabetes Solution. Just because you're following my way of eating does not mean that you read my book. I don't know. Also, you might check your free T3. People who have gastric surgery frequently get a change in their thyroid function. And the most common change is difficulty converting the hormone T4, levothyroxine, to T3, triiodothyronine. And T3 is the active hormone. So it happens that most diabetics to begin with are hypothyroid and have low T3s. And you may have even lower T3 than you had before. So it would be wise for you to check your free T3 and then follow the guidelines that I believe are in my book and certainly are on the recordings of these teleseminars and on my video in Diabetes University on treating hypothyroidism for the treatment of low T3. That is a major factor and the most likely factor in your problem. You might also reduce your dietary protein, and if you're taking insulin, reduce the amount of insulin you get. That doesn't mean that you replace the protein with carbohydrate. I have people who are getting reasonable amounts of protein and even too much for their level of activity and body size, so we can get weight off them by reducing protein, and if they're taking insulin, reducing the amount of insulin accordingly. Again, the guidelines are in my book, Diabetes Solution. But my main concern here would be the free T3. Is frequent sleepiness after meals and waking up groggy and grumpy from a nap a sign of sugar imbalance? Well, I don't know about the waking up groggy and grumpy, but I do know that sleepiness after meals is very common in diabetes. In fact, when I was a kid, I used to visit my grandfather, who lived in another state. I'd take a bus to see him, and he lived with my aunt. She would give me, in accordance with the then ADA guidelines, a sugar-free apple pie that she would make. It would be about 5 inches in diameter, so it wasn't a huge pie. It was about this big. And I'd eat the pie, and I'd promptly fall asleep because we had no blood sugar meters. My blood sugar probably went up to 800 or 1,000, and I was so wiped out that I'd fall asleep, and I'd sleep the rest of the day. And then my aunt would wake me up to take the bus home, and I'd sleep in the bus. So high blood sugars can certainly make you groggy and sleepy. The grumpy, I don't know about. I can't comment. Next question. I've read your book. If you are recommending a high-protein diet for patients with type 2 diabetes, don't they have to worry about gluconeogenesis? Gluconeogenesis is the conversion of protein to glucose with the help of some enzymes from the liver and even muscles and kidney. And indeed, this happens, and we do have to think about it. In fact, type 1 diabetics have to cover not just their carbohydrate, but the protein they consume with insulin. One of the big mistakes that the American Diabetes Association makes and that the insulin pump makers make is advising patients to inject insulin before a meal based upon the amount of carbohydrate you're eating, when you also have to take into account the protein. You also have to take into account the bulk of the food, which we discuss in my book, Diabetes Solution. So protein can raise blood sugar, but not gram for gram, not nearly as much as carbohydrate and not nearly as rapidly as carbohydrate. So a type 2 diabetic can be treated, for example, with small protein meals scattered throughout the day and have very little, if any, effect on their blood sugar if they have a very mild disease state. In fact, I have a new patient who I'm treating right now, a lady, whose treatment is 6 high-protein, very low carbohydrate meals per day. And her beta cells can cope with a small amount of protein, which may be 1 to 2 ounces per meal. So we do have to take it into consideration, but it's nowhere near the challenge that carbohydrate is. Why is a ketogenic, high-fat, moderate protein, low-carb diet dangerous? Well, first of all, I don't advocate such a diet. I advocate a high-protein, very low-carb diet, and whatever fat happens to come along with the protein. I don't advocate going out and looking for fat to add to your meals. I just don't think it's necessary or there's any purpose, except perhaps for those rare individuals who need to make as much ketones as possible. such as people with seizure disorders. There have been studies done with children with seizure disorders showing that for some of these people, a totally adequate treatment is a very ketogenic diet. So virtually no carbohydrate and pushing the fats. Is there any harm to this? No, not to my knowledge. In fact, as we indicate in the book, Diabetes Solution, the survival of mankind is based upon getting adequate amounts of ketones in the blood to keep the brain alive when there's a famine. When you're starving and have used up all your stored glycogen and there's no more vegetation around and you're hunting for animals to get some protein, you start metabolizing your fat. And when the body oxidizes fat and converts it to energy, one of the byproducts is ketones, which are an excellent substrate for the brain. The brain lives off the ketones while the muscles live off the fat. So ketones are essential for the survival of humanity. Doctors are taught this in medical school. I was taught this in biochemistry. But when they go on the wards and see children dying of ketoacidosis from very high blood sugars and dehydration, usually there's vomiting and very high blood sugars combined, the doctors get frightened of ketones. But what's killing these kids is dehydration. It's, again, described in my book. It's described on the tapes that have been made of my training sessions, and I believe are available at, let's see, at the site for this teleseminar, askdrbernstein.net. You could get the CDs of my training sessions at askdrbernstein.net, and there we go into more detail on the value of ketones to the existence of humanity, the essentials. Ketones are essential for the survival of humanity. Next question. Your book recommends waiting 4 hours between meals and snacks. What if your meal or snack has no carbs, e.g. meat or eggs or cheese? Well, I don't recall if I did say 4 hours. Maybe I suggested that for type 2 diabetics, you want to minimize the load at any one time, especially if you're not using pre-meal medications like insulin or GLP-1 agonists. So by minimizing the amount of food that you eat within a certain period, spreading out meals to 4 hours apart instead of eating every 2 hours or every hour, there may be some value in that. But I don't even recall saying it in my book or saying it on my teleconferences. What I do say is that if you're going to correct a blood sugar with insulin after a meal, you must wait at least 5 hours until the prior shot of insulin that you took to cover that meal has finished working. So basically what I say is don't correct blood sugars more often than every 5 hours. That's during the day. And at night, I recommend at least 6 hours wait between injections of rapid-acting insulin in an attempt to control blood sugars. Again, read the book if you want the details. Next question. I've had type 1 for 20 years and CVID for 7 years. Now, for your information, CVID has been discussed in my Dr. Bernstein's Diabetes University series. It's been discussed on my teleseminars. It's briefly discussed in my book, Diabetes Solution. It's a condition that affects about 25% of diabetics. The ADA has refused to publish this information in their journals, but it affects 25% of diabetics. It's an immune deficiency wherein people do not make enough antibodies. And the usual antibodies that are, or antibody groups that are deficient are IgA and or IgG and or IgM. So this person apparently has been diagnosed with CVID 7 years ago. Many of these people actually have the CVID since birth, but it doesn't get diagnosed until they have symptoms like frequent infections and malignancies and so on. Now, what should my blood IgG level be? Well, when your doctor orders lab tests of IgG, which is one of the three major immunoglobulins, they give a range, a normal range. And ideally, your IgG level should be in that normal range. Now, if you're receiving intravenous gammaglobulin, yes, she says that her last gammaglobulin infusion was 4 weeks ago. Well, the way they prescribe the gammaglobulin is to, ideally, if they had a medical choice of what's the best way to do it, you'd give a little bit every week, say. It's an IV infusion. If you're giving a small amount, that small an amount, it might take about an hour, hour and a half. But what they do for convenience sake, and also because of insurance compensation, they give it once a month or once every 3 weeks. On very rare occasion, they give it once every 2 weeks. For emergencies, they might give it right away. But because they're bigger doses taken less frequently, you start off with a peak, and then over the next few weeks, you're dropping down. So what they do is they start you off too high, and by the time it's time for the next infusion, you're too low. So it's not the ideal way of doing things, but it's the way most systems work. If it were ideal, you'd go up a little, maybe be high normal after a small dose 1 week, and then by the end of that week, you'd be low normal, and they'd give you a little bit, and you'd be high normal. That would be the ideal way of doing it. There are a number of reasons not to go too high. In my case, they went too high and did not track my serum viscosity level. I was going too high I was getting it every 3 weeks. I still am. But the dose was so high that my serum viscosity went up and I got glaucoma. And it was only until I started investigating that I found out that high serum viscosity can cause glaucoma. And I'm almost blind as a result of this. It's a disaster. And not all allergists or immunologists who monitor the administration of gammaglobulin are going to be frequently checking your serum viscosity level and adjusting doses accordingly. I had to learn the hard way. And if I hadn't been investigating on my own, we wouldn't have gotten the dose down, and I would probably be totally blind by now. So the story is, ideally you want all three of your immunoglobulins in the middle of the normal range, but the doctors are going to do the best they can in the light of the readings on your blood and what insurance permits. Also, some patients, let's say that insurance was willing to pay for weekly infusions, some patients would not want weekly infusions. They hurt if they're not done in an immaculate fashion, and it's not the happiest time in the world. Okay, let's see. What's next? What is Dr. Bernstein's opinion of the HCG diet? Is it a safe diet? The HCG diet is a diet, as I recall, a diet that involves supplementation with human chorionic gonadotropin, which is a hormone made during pregnancy. It should not be available on the open market, but it is. And it is potentially dangerous. There is an article on this kind of treatment at the Mayo Clinic website. If you go to mayo clinic.org, they have an article on the HCG diet, and they say that it is frequently, but not always effective, but that it is dangerous. So it's not something that you want to do. I would suggest low carbohydrate. I've been doing low carbohydrate since around 1977, probably around 1970. And it's now 2015, so that's 45 years, and I've survived. So I think that that's probably a lot safer than the HCG diet. Next question. How much fat and protein do you recommend for an average 150-pound man? I don't make the recommendations. It in part depends upon how many meals you have and how much you like to eat at a meal. I like my patients to feel satisfied but not stuffed. And since we're severely limiting the carbohydrate, the only things that remain are protein and fat. And since I'm not telling people go out and buy some fat and eat it, the fat is whatever comes along with the protein. So it's a matter of what it takes to make you feel comfortable. But there are computations that you can make. And when I sit down with a new patient, I look at the amount of exercise they get, and I do some estimating. And it's really more like guesstimating than estimating. The literature seems to suggest that a truly sedentary person, someone who doesn't go out and walk around, who sits around the house all day long, doesn't do housework, in other words, an invalid, needs 0.8 grams of protein per kilogram of body weight. And this is what they give to end-stage kidney disease patients. They at the very end, they try to minimize the protein to put off dialysis another few months. It's not been proven that they can do this, but some doctors think that it may be possible. So they take them down to the minimum, which would be 0.8 grams of protein per kilogram. So you have to convert your body weight to kilograms by dividing pounds by 2.2, and that gives you grams of protein. Every 6 grams of protein comes to 1 ounce of real protein food as you would weigh it on the scale. So a 3-ounce hamburger would have about 18 grams of protein. Now, what if you're more active? Let's say that you're a professional athlete. You might need between 5 grams and 10 and 15 grams of protein per kilogram of body weight. And you might be solid muscle and have a lot of kilograms of body weight. So that's the other extreme. And in between, if you take a person who exercises, let's say, for a half an hour a day, he might need 1.0, 1.1, 1.2, 1.3 grams of protein per kilogram of body weight. So it depends very much on how much you exercise and how strenuous the exercise is. So there's not a matter of my recommending how much protein you should eat. But the main guideline is what maintains your body weight at a healthy weight. And do you feel too full or too hungry? So if I want someone to lose weight, I'll reduce the protein below my computed amount. And if I want someone to gain weight, as I'm doing right now with a lady who's getting 6 protein meals a day, we raise the protein above the computed amount. So that's how it goes. It's not the simplest thing in the world. Read the book. It might be helpful. Diabetes Solution.